So I'm just going to talk to you for a minute about rapid onset medications. I already spoke a little bit about etomidate. So rapid onset medications are medications that have no reversal agent. In the ICU, we typically use etomidate, Brevital, Precedex, and Propofol. Those are the four that are known and widely used. Because they have no reversal agent, we need to be really careful in how we use them and that we have the appropriate equipment and people in the room when we do use them. Generally, we see these used for procedures where the patient needs to be sedated and their LOC needs to be decreased during that procedure and then brought back to the LOC that they were prior. Now, I know that's different when we intubate a patient, so there's a few differences that I'll talk about here in a minute. So what things would we need in our room? We're going to want them on the monitor. We would want to make sure that our vital signs are every 1 to 3 minutes during the procedure. And then we're going to want to make sure that that pulse ox that we talked about earlier is audible so that we know everybody is aware in the room if there's a change with the patient. The other things we'd want in the room are our suction. We want to have a suction setup so that we're ready to take care of any secretion issues with that patient or vomiting. And then, of course, people. We want to make sure the respiratory therapist is available to help us with airway issues, and then the provider, whether that's the independent practitioner or our MD. And so when everybody's ready and in the room, we have the drugs drawn up, that's when we communicate really well with the team and make sure everybody's ready. You ask them if the team's ready for you to give the medications, verify the doses, and then you are going to let the team know that you're giving them. So the RT should be at the head of the bed, ready to bag the patient. The physician should be ready to do whatever procedure they're doing, and then the nurse would be at the standby to alter vital signs or to administer fluids, whatever needs to be done for that patient. So I want to show you the charting here in Icentra. You would come down here to Procedure and Sedation Med Administration. You're going to click on that, and it's basically going to bring you into the pre-procedure timeout. You would go through that piece of it. Then you're going to come to moderate sedation medication, and it is actually a dynamic group that you're going to create. This way, if you give, for example, let's say you gave 5 milligrams of etomidate, and then you're going to give another 5, or you gave 50 micrograms of fentanyl, and then you give another 50 micrograms in 5 minutes. It allows you to chart that over time so that you can be accurate in your charting. Then you would actually go and back chart in the MAR the total dose once you know what that is. Because upon entering the procedure, you don't know quite how much medication you'll end up giving the patient. Then you're going to come into the next one, this procedure sedation monitoring, and if you've clicked into eyewear, it should help pull in all of these values for you. Those will come in. It's super important that you do this initial sedation agent administration time. This is how we gain money for the procedure. And so you want to put in and mark when you actually gave that first amount of medication. Then there's the post-sedation monitoring, which you're all familiar with as in the terms of modified Aldrete, phase 1 and phase 2. So you would be scoring your patient based on these criteria that pop up in each box. So whatever is happening with them at that very moment, then it gives it a score. Basically, they need to be able to be awake enough to verbalize their pain and that they are or are not nauseous. If they can verbalize that, then you've moved into phase 2. That's an easy way to tell that transition. Once they're back to their normal level of consciousness prior to you giving these medications, then you can be done with this part of it. So, as part of airway and intubation, I wanted to show you where these kits are. We're in one of our med rooms. These are located on the 4th, 5th, and 6th floors. This is our rapid sequence intubation kit for PUIs. And it's a temporary kit. So let me pull this out and we'll show it to you. So we have it listed on here: etomidate, succinylcholine, and rocuronium. So etomidate is a sedative. It has no reversal agent. So we want to be extremely careful when we give it. Generally, etomidate is 0.3 milligrams per kilo. So get to know what your patient's weight is and figure out that dose ahead of time before the physician tells it to you. Make sure they're telling it to you in milligrams or mils, and that you know which one they're telling you, so that you can give the appropriate dose. Pharmacy, if they're available, should help you and be there to help pull that up, but you would definitely give the etomidate prior to giving the succinylcholine or the rocuronium. Those two drugs are paralytics, so I don't know about you, but I would rather be sedated before I'm paralyzed. So you would want to make sure that you give that after you've given the etomidate. We're finding with these patients, it's extremely important that you do use a paralytic with them to minimize their cough response and make sure that you are not being exposed. The general drug of choice right now is the rocuronium because it does have a reversal agent. Okay. The dose for succinylcholine is 1.5 milligrams per kilo, and the dose for rocuronium is generally 0.6 milligrams per kilo. So the reversal agent for rocuronium is here in our Omnicell. It's called Sugamadex, and it can be given in doses of 2, 4, and 16 milligrams per kilo. If we end up giving that 16 milligram per kilo dose, which is the preferred right now, it cannot be re-administered within 24 hours. So just remember that if you've given that largest dose, you can't give it again to your patient for 24 hours.